2, 1.
Good evening, everyone. My name is Debbie Hicks and I'm a nurse consultant working in North London in primary care. And I've also got with me June James, who is an associate professor working at the University of Leicester and also a nurse consultant working in the University of Leicester Hospitals. We're just waiting for a few more people to join us. We have got a significant group already, which is absolutely brilliant. And we welcome you all to this session, which is moving on really from the last session that we did on insulin safety, and looking particularly at some cases from the perspective as what went wrong, what were the influencing factors and what happened thereafter. So both June and myself have got a couple of case studies, and these are actually real cases, although they're anonymized, of course. So I think we'll just give it a couple of minutes. If you haven't got a cup of tea or nip to the loo, please do while we're just giving a few more people the chance to join, and then we'll be on our way. So thank you for joining us. And as I say, we'll just wait for a couple of more minutes. Actually, we've had 2 questions already. So that's brilliant, because I really would encourage you to ask as many questions as you wish, whilst June is doing the biggest portion of the presentation tonight. I will be keeping an eye on the questions and feeding them to her at the end of the session. So please do put a few questions in there to make it interesting and interactive. We've got over 100 people now waiting, and I'm really pleased that you've been able to join us. I think June and myself was just talking before we started, and this is our last webinar of the year, and I have to say that we've had some real fun being involved in the webinars that Trend Diabetes have been providing for you. And I'd really like to take this opportunity to thank the ladies at Orange Juice Communications, because without them, I tell you, June and I would not be sitting in front of you now, because we suffer slight absences of IT literacy, but the girls keep us on time and on spot, so we're okay. We're managing. So I'm going to start now, and I'd like to welcome you all to this session. And as I say, I've already introduced us to you, but if June has actually got the control of the slides, so I'm going to ask June, can we have the next slide, please, June? So you can see here that we're going to run for about 30 to 40 minutes, so we're leaving plenty of time for questions. Can you make sure that you do ask the questions through the Q&A function, because the chat function is actually disabled, and you will all be on mute unless there's anybody that would like to ask a question live on air is fine, whichever way you provide, but please put your hand up if you want to do that. And there is an evaluation form, and if you complete the evaluation form, you can get your certificate of attendance from Laura Payne, as you can see there. Laura's in the background keeping everything going. So somebody's asked if we're recording this session, and yes we are, and it will be on our YouTube channel next week. Okay, thanks June. This is the disclaimer for today, in the fact that we're doing this without any sponsorship. We decided that we just wanted to finish off the year. We think insulin safety is really important, so we've had no sponsorship to do that this evening, and hopefully it'll be of use to you. So next slide, June, please. And at this point, I'm going to pass over to June, and she's going to take you through what we hope to achieve by the end of the session. Thank you, June.
Thank you, Debbie, for that really nice introduction. So by the end of this session, you will be made aware of the impact of insulin error in people living with diabetes. You should be able to identify common reasons for insulin error in the hospital and the community setting. You should be able to discuss new ways of working to reduce insulin error, and also know where to seek information and resources relating to insulin safety. I'm having a little bit problem moving my slides now, which is strange because I've just moved it before. Nope, let's try again. So, just a little bit of background. Now, we know there's 4 million people in the UK that have diabetes. There's also about 1 million people that don't know they've got it. So 92% of people with diabetes will have type 2 diabetes, but many of these require insulin treatment and other non-insulin therapies. 8% have type 1 diabetes and will require insulin for life. But if you look at that complete total of 4 million people, up to 30% of those people will be insulin treated. So insulin is very commonly used. And we also know that between 1991 and 2010, the amount of insulin users trebled, and that was in line with the numbers of people increasing with type 2 diabetes. So where do we look when we want to find out just how common insulin errors are? And unfortunately, there is no data from community settings. Hasn't been any data for some time. We checked with NHS England and they've no recent data either. So we're reliant on the National Diabetes Inpatient Audit, which is undertaken most years. So this audit takes place usually in September, and every single person with diabetes in a hospital is reviewed on that one day. So it's an enormous amount of work, and particularly for the nurses. So in 2019, 97% of the 193 hospital sites actually took part in the audit, and this included over 15,000 inpatients with diabetes. 1 in 6 had diabetes. So if we look at medication errors, 1 in 3 of the inpatient drug charts surveyed on that day had at least one medication error. Repeat, at least one, that means there were more. And when it came to insulin errors, 2/5 of inpatient drug charts had 1 or more insulin error. So insulin error is common. So Nadia also looked at the numbers of people that actually acquired diabetic ketoacidosis while they were actually in hospital. And it was 3.6%. And usually this is due to omission of insulin. So what else did Nadia find out? It said around 1/3 of the charts had at least one medication error, and that had reduced from 45% in 2010. But you know, that reduction really needs to be becoming much more apparent, doesn't it? 18% of the inpatient drug charts had one or more insulin error. It had improved from 26% in 2010, but you know, that's 10 years ago. And the proportion of inpatient drug charts with at least one prescription error had decreased, but not by much, by 2% in 10 years, or in 2 years. And although the proportion of glucose management and insulin errors, they remain static. So despite improvements in recent years, and there's been a lot of work done on insulin safety, the proportion of inpatient drug charts with medication errors is still too high. And this is what was written in the Nadia report. And that was the same, even if people had adopted things like electronic prescribing. So still not good. So I wanted to look at this 10-year data, and this is data showing inpatient drug charts with one or more medication errors in the previous 7 days whilst they were an inpatient. And if you look at 2010, which is in the first part of the bar chart, the first one saying 44.5% medication error. And then you look at 2019, which is in the pale grey, it's gone down 14%, so it's gone down, that's good. Prescribing errors had halved really to 16.8%. Glucose management errors reduced by about 6%, so not that much in a decade. And insulin errors had reduced by about 7%. So if you look at this box at the bottom of this slide, you'll see that the errors are down from 2010 to 2019, but from 2017 to 2019, there's really been no change apart from prescription error. So what does it tell us? It tells us there's still a lot of work to do. So what about people with diabetes that are in hospital? And people with diabetes in hospital are often very anxious about who's going to be looking after their insulin, and many of them want to look after it themselves. Some don't. Some are quite happy to say, actually, I don't want to manage my diabetes now. Here you are, you have it. So Nadia looked at the percentage of hospital sites with a policy or a guideline for self-management of diabetes. And you can see that from 2015, there were 63% of those audited had a policy, but that's only reduced to nearly 46% in 2019. So again, work to be done. And if you look in the other bar chart, the percentage of hospital sites with a policy or guideline for people to be enabled to self-administer their diabetes medication, actually, that's worsened. So 61% in 2017 and 65% in 2019. So ultimately, 35% of hospital sites still do not have a policy or guideline for self-administration of diabetes medication. So often insulin is locked away and the person is reliant on the staff having the time to come and bring their insulin and their equipment when they need it. And in the ward setting, that's not always easy, as there are often other emergencies that need dealing with. So I'd like to talk to you about Rachel, and this is a true case. She's 48 years old. She'd had type 1 diabetes for 32 years, so a long time. And she was clearly was well used to looking after her own diabetes and her insulin. So her usual insulin regimen was Humulin M3, so mixed insulin twice a day. and she was admitted with cholecystitis and had keyhole surgery. And that went very smoothly. And she was then discharged with insulin that was prescribed for her as medicines to take home. And it was prescribed on the ward. So let's think about what happened next. Well, she was readmitted 6 weeks later because she had diabetic ketoacidosis. Now, before this original admission, she'd not been an inpatient with DKA before. So she was treated on this admission with a fixed rate insulin infusion regimen, discharged on insulin as before. So the insulin that was prescribed on discharge before was rewritten. She was then readmitted to ICU 8 weeks later with diabetic ketoacidosis again. And don't forget, these are life-threatening emergencies, and she was on ICU. And so she was clearly extremely ill. She was cared for there, transferred to a general ward, which happened to be a diabetes ward, and then discharged. And she attended outpatients for review. And so what happens? Why has this happened? And that's what was asked when she attended for outpatients. Why is this happening, Rachel? You've been in twice with DKA and this never happened before. So she pulled her insulin out of her pocket and said, I don't know, because this is my usual insulin. So the prescribed insulin on both admissions for discharge was Humulin S, a short-acting insulin. She'd originally been on Humulin M3, which contained some long-acting, but she was only prescribed Humulin S, and she thought that replaced her original insulin. So there was no long-acting insulin given. And as a direct consequence of that, she developed DKA twice. So you might think, well, that shouldn't have happened the second time. But actually, the doctor that prescribed the first lot of insulin had written Humulin S. When she was readmitted twice for DKA, the doctor looked back on her TTOs for the previous admission and wrote the same Humulin S up. So it'd been written 3 times in general. And so it never should have happened. But what people would have been involved in this error, even if they weren't directly responsible? So one was the ward doctors who all copied the original insulin chart that was incorrect. And that included ICU and the general ward doctors, because nobody really checked to see why this DKA was happening. Nobody noticed that somebody with type 1 diabetes hadn't had a long-acting insulin. The pharmacist would have issued the insulin, but in their defence may not have known that Rachel didn't have any long-acting insulin at home. The ward nurses would have discussed with Rachel, oh, this is your insulin, this is what you're taking home, this is what it is. Nobody noticed she had no long-acting insulin. The GP surgery staff put it on repeat, the incorrect insulin. So that should have been checked. And where was Rachel in this? She should have known what insulin she should have been taking, and she clearly didn't, because when she told us what she was taking, she had no idea it was different to her usual, which contained long-acting. So this admission, these 2 extra admissions, were entirely preventable. And it just shows you only need one error and lots of other things happen to compound that. So just what I've been saying to you, if the usual insulin had been written in full, the Humulin M3 had been written in full, that would have at least been a guide to the fact she needed long-acting insulin. And the first prescribing doctor needed to check what the insulin was, but maybe it wasn't written. It's not clear whether it was. And if they weren't sure, she'd have referred to existing outpatient notes. And if you're transferring to a basal bolus regimen, you need to be aware you need long-acting as well as short or fast-acting. The second doctor copied the original discharge letter And as I've said, other members of the team should have noticed that there was a problem, as should Rachel. She should have known that the insulin prescribed was not her insulin and questioned it. Did she have an insulin safety card or a passport? We don't know. So Debbie's now going to talk to you about John.
So this guy I actually met while I was working in the North London forensic unit, and you can see here he's quite young. He's actually quite rotund, but he's a big guy. He's very tall, and you can see the medication that he's on. But unfortunately, he was admitted because of his mental health problems. He'd had paranoid schizophrenia for 6 years, which often causes major problems with hyperglycemia when they're in an acute phase where they often don't want to take medication, often have lots of food and usually quite high fat sugary food. And he was on the ward and his blood glucose readings were reading high. And of course, we all know, working in diabetes care, that the blood glucose meters that we have access to in the community only read high when it's above 33. So this is quite alarming. And he was given rescue medication. At the time, he was given Actrapid, or at least he was prescribed Actrapid insulin 4 units. Now, thinking of this guy's size, you can understand why he survived, because what actually happened was the nurses that staff the North London forensic unit are RMN trained, so they have very little general nursing training. And she got the drug sheet, she checked on the drug sheet and she saw that 4 units was to be given stat. She couldn't find an insulin syringe on the ward, and because there was only 3 members of the team, she couldn't leave the ward. And so she checked with another nurse that was also an RMN, and they used an ordinary syringe, an ordinary 1 ml syringe. And instead of giving 4 units, they gave 0.4 mils, which was checked again by the other nurse, and the injection was given. And when the charge nurse realised the mistake, he raised the alarm, and John was actually taken from the ward at the forensic unit, and he was taken to the nearest A&E hospital. And whilst he was in A&E, his blood glucose level only came down to 24 millimoles per mole. No, sorry, it was litre. Why do you think that was? Why do you think that his blood glucose level only came down to 24? Thankfully, he was well, but they actually gave him 40 units of Actrapid. But because of his size, it had little effect overall on his glucose levels, which, as I say, thankfully, he survived. Next slide, June. So obviously there was an assessment of the situation, and an action plan was formulated. And so now basically what happens is the forensic unit only has Nova Rapid Flex pens that are available throughout the unit, because with a flex pen, you can only give the amount of insulin that is prescribed. There's no way that you could give 10 times more the dose using a flex pen. But of course, we had to do an extensive training program throughout the unit purely because these were mental health trained nurses. They had very little general training. They had little knowledge about insulin, about the effects of insulin, and etc., etc. And what we did was we revised the whole insulin prescribing algorithm, because what people didn't realize is that 1 unit of insulin is only likely to bring that glucose level down by probably about 2 to 3 millimoles per litre anyway. And because this guy was so big and his glucose level was high, then he managed to survive that insulin error. And now we make sure that there is a dual meter on all wards, there is a revised insulin prescribing algorithm, and we also have hypo boxes on all of the wards. But it took an insulin error for, you know, the management, including, you know, the nursing directors, to realise that the lack of knowledge within a unit that has a high proportion of people with diabetes, albeit they're quite young, but you will appreciate that any of the antipsychotic drugs actually causes hunger. And because of the sedentary life of somebody with a diagnosis of paranoid schizophrenia, that, you know, there is a high risk of type 2 diabetes in this group of patients. But it was a case of what you don't know, you don't know. And, you know, it was only when I was able to go into the unit and actually understand what was happening that we realised that, you know, there was a major risk of possibly more insulin errors and potentially a fatality. So, you know, it is about education, but it's making sure that people are practicing safely too. Thank you, June. So that was a person who was actually in a hospital state, really, because the forensic unit is run as a hospital base because people are unwell mentally. But this is a case study, again, that is a real case, and it happened within our district nursing team. And you can see here there was an elderly lady with mild dementia. However, she was living on her own. And you can see there that one of the district nurses had this lady on her caseload, and she was regularly visiting this lady to give her 20 units of glargine once a day. Now, I'm sure if you work in the community, you will realise that for district nurses to administer insulin, it's not always at the best time for the individual, and it really is determined by the workload of that individual. And often the workloads are significant. We're getting more and more people needing to go onto insulin, and often they're not able to administer this themselves. But what happened was the regular nurse got held up, but her colleague thought, as she was visiting next door, she'd do her a favour, and she went in and gave this lady her insulin. And she phoned her colleague and left a message on her phone to say, "Don't bother going to Grace, I've already given her insulin." Unfortunately, that call didn't connect with the regular nurse, and she visited the lady sometime later and actually gave the insulin. and she didn't look at the notes because she knows this lady well. She does it on a regular basis. And because of the lady's mental health state, she didn't say anything. She didn't tell the nurse that, you know, somebody had already given her it. And when the district nurse went to write the notes to say that she'd administered it, she realised that the insulin had already been given. So what should she have done next? Because, you know, this is an elderly lady, she's vulnerable, she's living on her own. So what would she need to do to make sure that that actual insulin error was made safe for that individual? So, you know, I hope that you're thinking along the same lines as I am, and you can see next slide what happened. So before she did anything else, she actually gave the lady some extra carbohydrate, which was an attempt to make sure that she wasn't at risk from hypoglycemia. And she also told the lady herself that there had been a mistake, because, you know, that's part of our C's, isn't it, candor? Actually making sure that if an event or an error occurs, that we're actually telling the person, involving the families, etc. But she also informed the person's GP and her line manager. And within the district nursing service that I worked alongside, they used the Datix forms to record any errors or incidents. But what she did do, what was completely appropriate, is that she actually visited the lady late afternoon to check her glucose levels, and also encouraged her to have extra carbohydrate, because there is a risk that the glucose levels could drop and also cause hypoglycemia. And also she arranged for the Twilight team to visit during the evening to check the blood glucose level again. But thinking about this situation, what would you have done, or would you have done anything differently? And it was very much a kind of order of the day throughout the district nursing team as a whole across Enfield, that the first thing that should happen after you've actually greeted the person that you're visiting is that you check the nursing notes. You don't assume that you know, you go every day or every other day and you carry on what you normally do. It is really, really important that the notes are checked, because there could have been a visit from the GP, there could have been a visit from somebody else, and that would have been documented in the notes. So whilst this lady was okay and she was safe, the biggest problem here was that the notes weren't checked, because if they had have been checked, that the nurse would have seen that the insulin had already been given. Unfortunately, because she wasn't able to answer her phone, she was in another patient's house, she didn't get the call to say, don't worry, I've already done this. So the first nurse, thinking that she'd done her colleague a favour, actually caused the problem in the first place. And it's about communication, but it's also about checking the notes before anything is done, just in case anything has changed since you visited the person the last time. So thank you, June, and please do carry on.
I'm going to talk about Mary, and this is a true case too. So She's an 85-year-old lady prescribed insulin via an insulin pen, and the district nurses went every day to give it because Mary was visually impaired. But it happened one day that her usual nurse was off that day, and so a nurse who wasn't familiar with that particular insulin pen visited to administer the injection. She didn't know how to use the pen, and so she tried one pen and managed to jam it, and then she tried a second insulin pen with the same type, and that jammed because she didn't know how to work it. And then when she tried a third one, it broke. So the district nurse thought, well, I can use a syringe because I've got one in the car, and I really don't want not to give this lady her injection. And it was a glargine injection. So hindsight's a wonderful thing, but actually it could have been delayed until the proper device could have been sourced. But anyway, the syringe she had in the car was not an insulin syringe. It was a normal syringe you used to give people an intramuscular injection. And she tried to calculate the dose because it wasn't an insulin syringe. And she administered the insulin. And 6 hours later, the lady collapsed and died because she'd had a massive overdose of insulin. The nurse involved realised later on that day that she must have given the wrong dose, but by then the lady had already died. So this was a case that went to the coroner's court, and it's a tragedy for everybody. A tragedy for the older lady, a tragedy for the nurse who was taken off the nursing register for some time and had to retrain, but also who continued to beat herself up really as to what had happened, because she was just trying to help by using the another method of drawing up insulin from the pen, so the lady didn't have her insulin delayed. So it was a complete tragedy for everybody involved. And what do we learn from it? Well, first of all, that you should only be giving insulin if you know how to use that device, and you should be competency assessed as to how to use a device. If you're going to use a syringe anyway, it needs to be an insulin syringe. But actually, it's prohibited to draw up insulin from a pen cartridge or a pen using a syringe anyway. And I guess in hindsight, they could have waited till the nurse could go back to her surgery, collect an insulin syringe if it had to be done that way, or get another prescription for insulin because it was an emergency situation, because I don't think the lady would particularly have come to harm with a delay, but she did come to harm. So as a result of this, NHS Improvement sent out this patient safety alert, which says very clearly not to draw up insulin from an insulin pen or cartridge using a syringe. It's prohibited. So, and if you're really going to do it in an emergency situation, you better make sure it's an insulin syringe. But really, it's a dire emergency that you would do that. PCDS, the Primary Care Diabetes Society, also issued a warning to say this too. So, just to summarise, we've got quite a few common errors, and we've addressed some of those today. So in the hospital setting, often omission of insulin is a really big problem. The insulin probably should be given with the breakfast perhaps, and it's missed because there's some emergency, and then people realise at lunchtime that the blood glucose is off the scale and that person didn't have any insulin. Poor timing of injection. Sometimes you might find the insulin's not given with the meal, or the meal's been given but the insulin's locked in a cupboard. Not good. Incorrect prescribing, even with electronic prescribing, because not all insulin products are always included in the portfolio of available drugs. People on intravenous infusions, maybe not giving any long-acting insulin when all the guidance says continue the long-acting insulin even when people are on an insulin infusion. Delays in recommencing insulin after an infusion is a very common error, leading to DKA in some instances, as we've heard. And not reducing doses of insulin when people aren't eating or their intake's reduced. So if somebody's on enteral feeding and the tube blocks, but nobody thinks to reduce the insulin. And the old chestnut, where people put a U after the number, doesn't need to be written. The insulin, you just write the number and not a U, because people think it's a naught and give 10 times a dose. And in the community setting, again, poor timing of insulin. District nurses can't be in 20 houses at the same time, so it's difficult to get the timing right. There are different insulin products you can give now where it's not so crucial to give it at a specific time. Again, electronic prescribing is not always the best thing, as not all insulin products are included in the formularies, and sometimes people won't scroll down far enough to get the right one, or they don't think about the fact there's a number on the end of the insulin, like Humulin M3 or Humulin I, those sort of things. Not reducing insulin when people are not eating properly is very common. So if somebody's got advanced cancer or is in end-of-life care, it may be that their insulin doses aren't reviewed because everybody's concentrating on making sure we've got good end-of-life care going, and people have been admitted with hypoglycemia in those instances. And this is something that's really coming to the front now. So delays in reducing or increasing insulin doses in the housebound. So it may be that there's been a telephone call from a diabetes specialist nurse to say, this lady needs her insulin doses increasing, or they've sent a fax to the surgery, but then somebody has to go to the house to update the community nurses, and that's what happens in some areas. So a doctor has to prescribe it, and then it's got to be changed on the charts in the house or even in care homes, and often that's delayed. And using tight glucose targets, particularly in the frail or older people at risk of hypoglycemia, and in people with chronic kidney disease, because insulin is excreted via the kidneys. So with chronic kidney disease, you don't need as much insulin, generally speaking. So NHS England, the National Diabetes Inpatient Reports, Primary Care Diabetes Reports all recommend that training should be provided for every healthcare professional who dispenses, prescribes and administers insulin. This should be appropriate to their level of responsibility and include an assessment of competency. Now, some of you who have maybe not heard these type of talks before will think, oh wow, fancy that, when did that come in? Well, that came in 2010, and we've still got a long way to go to make sure that this happens. NHS England Improvement, NHS Improvement are very keen that electronic records be used because they think it might reduce prescribing errors, but actually that'll only happen if all the different insulins, and there's more than 30, are recorded on the system. So in summary, insulin errors are common, whether in the hospital or the community setting. Where possible, people living with diabetes and who have capacity should be enabled to manage their own insulin. More than 10 years on, if somebody's admitted to hospital that can manage their own insulin, they should be enabled to do so. And staff training and competency assessment must be in place, and staff should be assessed regularly. And where I work in Leicester, that's annually, we have to do annual e-learning training. So insulin errors are everybody's responsibility. It's a no blame culture, but we want to stop them happening, and we all need to work together to stop that. So just some resources for you. So on our Trend Diabetes website, you will see this leaflet, Keeping Safe with Insulin Safety. This is for people living with diabetes, as is the leaflet opposite, which is about hypoglycemia. So when anybody's on insulin, they should know exactly what insulin they're taking. They should use a crib card, a little safety card as well. And hot off the press, Trend Diabetes has made a free-to-use e-learning module for staff. Now that can be is only downloadable onto hospital, CCG or primary care networks. So it would go onto your own e-learning platforms. There's a list of 10 assessment questions, and we would recommend that somebody does this course every year. And as part of this, Trend has undertaken to provide this course free, so no trust, CCG or PCN will pay for it ever, and we will update it annually because the types of insulin we use seem to change on a minutely basis. So please let your learning organisations know about this, your electronic learning system people, because it's sitting there, just needs to be downloaded completely up to date. So with that, thank you for listening, and Debbie and I are happy to take any questions.
Okay, so there's been quite a few people asking about the YouTube channel, and actually if you just put Trend Diabetes into YouTube, it should come up almost straight away, and you can find all of the webinars that we've done this year, which will actually mean that you can access ones that we've done at the beginning of the year and during the year. So please do have a look. June, there's a question here that actually came up at the beginning, and it says here, a patient prescribed 40 to 50 units of Nova Rapid, but only wants to self-administer 10 to 15 units according to the amount of meal taken. Is this possible?
Well, it's absolutely possible. I'm not surprised that that person is quibbling about the dose, because I guess in my career with diabetes, which has spanned a long time now, I've only ever seen one person on that type of, those sort of doses of a fast-acting insulin. 40 to 50 units with a meal, I would be definitely querying that. It would make me wonder if the person has type 2 diabetes and is severely obese. So a bit like your chap in the mental health unit, where somebody could have 40 or 50 units of Nova Rapid in one go. When people learn how to manage their insulin according to their meals, it starts on 1 unit of insulin for every 10 grams of carbohydrate. I would guess that this individual knows exactly how much insulin he needs to take, and if they want to take, what is it, 12 to 15 units, that sounds reasonable. Okay. Always listen to the person with diabetes. They know more than we do most of the time.
I guess, June, that it could have almost been an insulin error, that it was actually saying 4 to 5 units, you know?
Yeah, it probably was. We've probably got a U in there. I have seen another error similar when I was on the wards, and I was not in the hospital I work with now, and somebody was written up for 30 units of insulin, at least that's what they thought they'd written up. So it was 30 units of a long-acting at night and 30 units of short-acting, but the medic had written mils. 30 mils, but actually the person in the bed, in the hospital bed, said, I mean, she thought it was quite funny. because she was with it and she knew that that was absolutely wrong. But what if she hadn't? You know, I mean, the nurses knew it was an error as well. But, you know, it's so easy in a hurry to either write the U, so you get 10 unit overdoses. People have died of that, of 10 times the dose. There was a lady in Scotland that should have had 4 units of Rapid and got 40 and died. You know, see, these are really serious errors, and I suspect this was an error.
So we've got another question, and the question is, what is a safe percentage increase of insulin if the patient's blood sugars are running regularly over 20?
Okay, so when you're working out the percentage, and it's not so easy, so often if you've got a policy in your trust or CCG about adjusting insulin, it'll say by 10%, won't it? It is in most cases. But there are times when you're going to need a lot more than that. So how I was taught is it depends how much your insulin you're actually on. So if you're only on 10 units, then you might just move it 10%. But if the blood glucose is over 20, you're probably going to need more than that. This isn't a fine, it's not a science, it's an art. And how much you increase it by depends on your level of confidence and how well it's embedded in your scope of practice. So I was always taught, and I don't know if this is written in stone anywhere, that when you get to units of insulin, so somebody's already on, say, 26 units, you're going to need more than 10% to make a difference. So I would probably go by 4 units in that scenario. And if it didn't work, then the next time I was adjusting it, I might use more. So it's not a science, it's an art. But to be on the safe side, if you really want to err on the safe side, you increase by 10%. If you're more confident, you can increase by 20.
And I guess, June, that certainly in type 1 diabetes, we would be always guided by the absence or presence of ketones. That's
right. Because then if you're ketotic, and this is a whole different talk, you're going to need a lot more insulin to get rid of the ketones. You don't worry about the blood glucose, you worry about the ketones. So you need to have enough insulin to get rid of the ketones. It's a different talk.
Okay, so we've had quite a few questions about how do people access the mandatory training, the e-learning modules. So actually Laura, our moderator, has actually given us the website, so I will read it out slowly. So it's https:// trenddiabetes, all one word, .online / insulin safety e-learning / and if anybody still wants that web address, then Laura can always add it to your certificate of attendance when she replies to your email. But another person has asked, are there any licenses required for multiple module access in different organisations, Joe?
I don't actually know about that. We've not been asked for, we wouldn't be given, what we would be doing is handing over our e-learning to your organisation to manage themselves. So if you were to click on the link Debbie's given you, you won't see our e-learning, but your electronic learning systems manager will download the information on there to their systems, and they do that for a system, I guess, akin to a DVD. So it can't be done by an individual. It has to be done through an organisation, because we need the organisations to manage the learners that are on it. So, for example, in my hospital in Leicester, there's 2,000 employees. So they would manage who should do the module, and they would know if they've completed it, because it's on their own system. If you want to have a view as to see what our e-learning looks like, there's a taster menu on our website, so you can go onto the taster module and have a look there. It lasts for about just under the hour, 45 minutes to an hour. You can dip in, dip out if you're really busy. You can do half of it and go back later, and then there's questions at the end. So it's very, very user friendly. So have a look at the taster menu. So in a way, we're not looking at a license for an organisation. We're handing it to you as a free download. Does that explain it?
I think so. I think that's explained it quite clearly. I want to go on to just a question quickly that somebody's asked. What is a dual meter? Well, that was actually something that I mentioned, and what I meant was a dual meter is one that tests not only blood glucose but blood ketones as well. And actually, if you look at NG17, which is the management of type 1 diabetes, NICE actually recommend that anybody with type 1 diabetes should have access to a dual meter, because ketones are extremely important, and if they're able to manage ketones and have got the right education, they can actually stop a hospital admission in most cases. So it's really, really important. So there is another question, which is quite a long one, so I'm actually going to see if I can read this one out. So somebody said, we teach prescribers and it would be useful for all to see the e-learning package so that they might spot these errors. Is it possible to get access for prescribing students? They are serious errors and nothing we can do to spot them, or anything we can do to spot them, the better. Not for the meeting, so email is, and we've got an email from this person. So thank you for that person. And I guess that in this situation, June, it would be the organisations that are teaching prescribing, wouldn't it, that needs access?
Yes, and I work for Leicester University, and I'd be more than happy for that to happen. So as long as it's come from a university or a college where they teach, where they've got a prescribing course, we'd be happy for us to share that, as long as they load it onto their systems.
So there you go. If we've got your email, so perhaps one of us can pick that up. Thank you. So another person has asked, in community nursing, are you a fan of having a range of insulin prescribed if the blood sugars are above certain levels? So I guess what this person is saying, should we have perhaps a spare fast-acting insulin pen available in possibly somebody that's only having basal insulin or maybe pre-mixtures? What do you think about that, June?
I think it depends on the individual that's having the insulin in the house. If they're self-administering and they might muddle up the pens, that wouldn't be good. If they're reasonably competent and they know that they never use that unless there's a situation for which they'll need to because their blood glucose is really high, that's fine. So I think it's dependent on you assessing the capacity of that individual, because what we don't want is the pen devices being muddled up. So, and that used to happen many years ago when I was on the community, where people would pre-draw insulin syringes up for the week. Did that happen in your area, Debbie? They were left in margarine tubs.
Yeah,
and one said morning on it and one said afternoon on it, and they might be two different insulins. Well, that was prohibited some time ago now.
Yeah.
So it depends on the capacity of the person that's going to have both insulins in the fridge. But it does happen that there is a fast-acting one left in the fridge, and you know, certainly our paramedics are used to that, because there may be an emergency care plan for that person where they know they're going to have to give some fast-acting insulin.
Okay, so there's another question here, which is interesting, which says, would you recommend the Trend Diabetes module instead of the 6 steps to insulin safety, or do both? I was one of the authors on the 6 steps, so you're not asking me an easy question. The 6 steps module has just been revised, and it's now saying it's all for primary care staff. And it has had some revision, and the new insulins have been put on there. So it's up to you to decide which format you like the best, actually. I think it'd be useful for you if you're used to using 6 steps, it's embedded in your trust, then it's probably for you. But it doesn't include anything about hospital care. Now, the new module, which I was also an author on, we've made sure we've actually put information. It's not a massive amount, but we needed to address the needs of hospital and community staff. So we have put about intravenous infusions in there. And so it's really, you need to decide what the needs of your organisation is. But actually, it's all the same insulins, and it's all the same, more or less the same information, except one's got a hospital in as well. And you would need to have a look and decide yourself. So I'm going to sit on the fence, because although I didn't do the revision for the 6 steps, there's very few slides that have changed from when we made the first one. Does that help? Yeah, thank you. I mean, one of the things that is slightly different, certainly at the moment, is that you can have this directly downloaded to your educational platform within your trust, and we've actually agreed to update this on an annual basis, and that will happen forevermore. Previously, there was a charge to hospital trusts to actually download these type of modules onto their own platforms, and that could have been a barrier, which is why we've made it available free. And with the e-learning that Trend Diabetes have actually just developed, we do have the support from the 3 main insulin companies, because they were very keen to make sure that everything was up to date. But as June said, it's really up to you. You can see the taster version. I know that you can actually do the 6 steps on your own, and you can keep your own certificate of attendance, but unless you show that certificate to your manager, your organisation won't know that you've done that. So that's the only difference, really. There's another question here, June, that says, can a care home or a nursing home be able to access the e-learning for their staff?
Well, we haven't designed it for nursing or care home staff particularly, because we're in the process of making some separate e-learnings for them. So we thought it was important really to address the needs of nursing home staff, because that's where you're going to get qualified nurses usually, more so than in care homes. So we are in the process. Our January project next year starts with doing 4 protected e-learnings for nursing home staff. But there is another piece of work we've been involved in as well, Debbie, haven't we? We've been involved with NHS England,
Yes,
on doing a specific insulin course for unregistered nurses and social care workers, so that they can administer insulin. And it's a source of great frustration to us that we were asked to work over Easter to get this done. And we did it really quickly over the whole of Easter because it was urgent. And it hasn't been launched by NHS England yet, and we're in December. But we live in hope that that whole training package will be available very soon, so that care assistants can go into people's homes and administer insulin, because there's no reason why not if they're properly trained. I mean, 7-year-olds give their own insulin, you know, as we know, because we've seen them do it. So so there's a whole programme being developed for our nursing home staff.
an interesting one here from somebody that works in a hospice is asking, we only have urine ketone testing strips. Should we, and how do we obtain a blood ketone testing meter? Which is very interesting because, you know, if that person who is, you know, having end of life care has type 1 diabetes, then June, what's your thoughts about that?
Well, you know, Debbie and I have been doing this job a long while, so I know, and Debbie knows, how to alter insulin according to a urinary ketone test. It's not so easy because the urine's been there a long time, so it's not so accurate. So on our sick day rule guidance, we stipulate what you can do if it's a urine test as well as a blood ketone test. But quite honestly, if you contact any of the companies that produce the blood ketone meters, they'll give you one for free. And then all you need to do is order a pack of strips. So I think that all organisations that look after people with diabetes should have a ketone meter. I don't think people with type 2 diabetes should have a ketone meter because they don't usually need one. But if they're unwell, all the latest guidance says that if they're unwell, they should have a test for ketones, whether they're type 1 or type 2. So I would say that any organisation or department should have a ketone meter because they're free. You only buy the strips.
Okay, so we've got an interesting one here. That it's somebody working in a nursing home and they're asking, should the night staff give insulin to patients before they go off and then leave the breakfast to the oncoming day staff? What do you think about that?
Well, I think it's probably because, you know, it's easier because the day staff can get on and do the breakfast as soon as they arrive and not think about the insulin. I mean, you're a bit open to a problem because the night staff might give it and there might be a delay in the food coming out. So you're risking that person with hypoglycemia. So I think it would just depend how well that was embedded in your practice. So if it was absolutely clear that the food would be given as soon as the day staff arrive, it would probably be okay. But normally they're having a handover. So I don't think it's particularly, it doesn't feel safe to me. I think that although it went out of fashion, Insulin rounds are the thing to do. So when I was on the ward, and it was a while ago, we would have our insulin charts ready. We'd have a kidney dish with our insulin supplies on it ready. And as soon as the day staff came on and were ready, the person had their insulin and then they had the breakfast. So I think it just takes a level of risk out. But while I'm talking about that, I should just say that for certainly in hospitals, one of the commonest issues is when they have their insulin, say with the evening meal or even at bedtime. But of course, well, the evening meal really, because there's no bedtime snack often given. So you're much more likely in hospital to have a middle of the night hypo, because you're not going to eat from when your insulin's given, say at 5:30 in the evening till the next day at 9 o'clock or 8 o'clock. So certainly in some hospitals, like I know in Ipswich, the evening snack is written on the drug chart to make sure that people that have tea time insulin have a snack before bed. So I think the timing with insulin is important. If it was me, I'd rather in that nursing home that my insulin was given probably by the day staff when the food was nearly there. Is that what you do, Debbie? You work in the community?
Yeah, I mean, the last thing you want is somebody to have their insulin and then, you know, somebody collapse, or, you know, there's a fire alarm or any distraction that might go on that means that that person is you know, delayed getting the food. And certainly, you know, these people are frail and vulnerable by nature that they're in a care home. So the last thing you would want to put them through is a hypoglycemia event, because, you know, we know that hypoglycemia can actually precipitate arrhythmias and, you know, potentially risk a fatality. So you really don't want to be risking that. But just one query regarding the block with the insulin administration delegation policy. Somebody's asked, so what's the block with this training launch? And the simple question is, we don't know. We honestly have written many emails since April asking for this, especially the current situation with COVID, because, you know, we've got quite a few district nurses that have been affected by COVID, and so either needed to self-isolate or even potentially be ill, and that cuts down the number of people available to get round, you know, people to give them their insulin, and we just don't know. We've even involved Partha Carr, who, as you know, is one of the assistant director within NHS England, and he hasn't been able to influence this. So we really don't know what the blockage is. But, you know, if we get a few queries from people, certainly, you know, if you think it's a problem, then write to us at our email address, and, you know, we'd be happy to collect these queries and forward them on to Ruth May perhaps, and ask what the issue is, on behalf of, you know, nurses that think, you know, it's important to have this out and about. So you know.
So can I just say, Debbie, that training program that's been developed contains a whole e-learning program on insulin, including administration, how to give insulin. It's really comprehensive. And what I don't want to do is have to go back soon and start adding extra insulin that's just new coming to the market when it hasn't even been launched yet. It needs to be launched. So any support from you guys in writing emails to say, where is it, when is it, you know, we'll pass it on and be happy to do that.
Okay, so we've still got questions coming in, and it's 8:15. So I'm just going to look at this last question, and then I think it's time for everybody to have a break and unwind for the evening. But somebody's actually asked, what's the best insulin that's suitable for newly diagnosed children? Well, I haven't looked after children in the whole of my career. However, June has, and she's dealt with transition clinics. But I suspect that any child diagnosed with type 1 diabetes or rarely type 2 diabetes, their paediatric service is going to know exactly what to do and how to support the family of a person with newly diagnosed children. So, but what do you...
I can answer that, because all children need to be on a basal bolus regimen. So in the dim dark past, it was felt by paediatric teams that it was a bit cruel to give children more than 1 or 2 injections a day. But in more recent years, it's been found that actually they need to have a basal bolus regimen right from the start, right from day one. They go on to basal bolus regimens. You know, they may come off some doses while they're in a honeymoon phase, then it's basal bolus, and then what's happening much more commonly now, because I've not long finished doing transition care, and I also went to the children's pump school in Leicester, which is fascinating, is that ages 7, 6, 7, they're going on insulin pumps. I mean, these children are really adept at manoeuvring and working insulin pumps better than grown-ups. So they go into school once a week for a few hours, a half day, and they learn how to insert their cannulas and how to manage their pump and how to carb count as small children. So they need to be on intensive regimen. So usually there's a long-acting analog usually, and then fast-acting if it's a basal bolus. Because we weren't doing them a kindness before, they'd come to us at the age of 20 and have severe eye disease because they hadn't had, it wasn't a kindness, they weren't controlled, the diabetes wasn't controlled. Now it's basal bolus or pumps. So I hope that helps.
Okay, so I'm conscious of the time. We've had lots of questions and I do appreciate that. There's been a lot of interest on this subject, and that's great because we do need to keep working on this. We need to keep trying to get those insulin errors down, because at the end of the day, at the end of every insulin error is a person with diabetes. And, you know, for me, that's the biggest motivator, that we need to help people with diabetes and not put them at extra risk because of our lack of knowledge or, you know, lack of information. So I'd like to thank June. That was a great session. And I'd like to thank the ladies behind the screen that have been answering some of the questions when it's been a technical thing. And I hope you've enjoyed it. And please do remember to fill your evaluation form in, get them to Laura, and she'll send you your certificate of attendance, which is really important because the 1st of December was my revalidation date, and I've got all my information in, so I'm okay for the next 3 years now. I'm kind of registered and allowed to practice. So things like this, if you can just write them up very quickly, they're useful for your revalidation. So thank you very much, everybody, and good night.
Good night.